I appreciate that very much. I did learn quite a bit. Our next speaker is Dr. Jaideep Kapur. He is a double doctor. He's a PhD and an MD, and he's the Eugene Meyer III Professor of Neuroscience, Professor of Neurology, and the Director of Neuroscience Center of Excellence in the University of Virginia School of Medicine in Charlottesville. He provides care to epileptic patients, and he's a member of the Dreyfus Comprehensive Epilepsy Program. He's got a long-standing interest in the neurobiologic mechanisms underlying prolonged self-sustaining seizures, such as called status epilepticus. He's got a number of laboratory studies, and including rapid plasticity of GABA and glutamate-mediated neurotransmission. He's also studying the regulation of seizures by hormonal fluctuations, and he's been the recipient of grants from the National Institute of Health, Epilepsy Foundation, Cure Epilepsy Foundation, and the Department of Defense in his research efforts. He's served as the president of the American Epilepsy Society in 2010, and he's served on numerous grant review panels for the NIH, Cure Epilepsy, Epilepsy Foundation, and other foundations. We're very grateful to have him join us here in Ogden, and welcome Dr. Kapur.
Thank you. Thank you so much for inviting me. This is my first time in Ogden in Utah, and this is a beautiful, beautiful state. So maybe I'm going to have, let me just switch this one off. This okay? So I'm at University of Virginia, and I hope many of you know that Navin Varma actually trained there, did his residency at University of Virginia in Charlottesville. Let me begin by just giving disclosures. I've got no commercial support or consulting agreements, and as was said in my introduction, I do receive grant supports from NIH, Department of Defense, Epilepsy Foundation, and Cure Epilepsy Foundation. So what my job has been made much easier by the last talk. You saw lots of examples of seizures and epilepsy. What I'll try to do is to try and classify seizures for you. I believe classifying seizures is important in order to pick treatments and medications, and then get into definitions of seizures and epilepsy. We have a brand new definition of epilepsy. It's being adopted as we speak. And it begins to address some of the last question that was asked. When do I start my patient for treatment of epilepsy? Well, it's the moment you diagnose them with epilepsy. And let's see what is the sort of considered wisdom of International League Against Epilepsy and in redefinition of seizures and epilepsy. We'll talk about focal and generalized seizures, then talk about some of the medications. You've heard about them, the ones that are in common use for these kinds of seizures and epilepsy. Then I'll talk about comorbidities in epilepsies, what goes with epilepsy, what do you look at when you see a patient with epilepsy, what is it that you should be looking at beyond the seizures. And in the epilepsy community, we are very concerned about going beyond seizures. Now that we have 10 or 12 seizure medications, we are not just content controlling the seizures, but looking at other things that go with seizures in our patients. And I'll end by talking about issues that are specific to women with epilepsy. As mentioned, it's an area of interest for me from research perspective, but also for treatment perspective. So seizure is just a clinical manifestation of an abnormal synchronous discharge of a group of neurons. That's a great neurobiology definition. None of my patients in 20 years has ever come to me saying, I had an abnormal discharge of neurons. So what they come in is saying that they had a sudden neurologic deficit, a paroxysmal neurological event, which was undiagnosed. Something happened, sudden neurologic change. That We go through a series of things. Was it a stroke? Was it a TIA? If there was active convulsion, then it's much easier to define that this could have been a seizure. And once that, so that history that you take in your office is probably the most important thing. I'll talk about EEGs and MRIs and everything, but really what the crux of understanding seizures and epilepsy in an outpatient setting is taking a good history. And longer you spend asking questions about what happened, what did you experience before, what happened, if there are witnesses. Even though I'm talking about adult epilepsy and I see adults with epilepsy, the person I want to see with them is either their girlfriend or wife or significant other or parent. If the mother can come, that they make my life much easier because they can give me the history of birth, early birth injuries. Is this person had epilepsy as a child that they appeared to outgrow and then they came back as adults? So those kinds of questions. Was the head trauma before 6 months ago, 8 months ago, a year ago? All those things are important to start asking right at the beginning. So what is the new definition of epilepsy that's being debated? And you can actually go to the website of International League Against Epilepsy and give your opinion. Basically, as you just heard, at least 2 unprovoked seizures occurring more than 24 hours apart, we all agree that's epilepsy. If you have 2 unprovoked seizures that are more than 24 hours apart, we all agree that that's epilepsy. Question is, can you have 1 seizure and then epilepsy? And there's growing consensus among experts that if you can be reasonably certain that this person is going to have more seizures after 1 seizure, you can call it epilepsy. Right now, they're giving a figure of 60% probability. God only knows how you calculate 60%, at least I haven't learned how to do it. So I took out the 60%. But if in your clinical judgment, so what kind of a clinical judgment would you have? You get a patient with a seizure, you order an EEG, and they say they have generalized spike wave discharges on the EEG. I would be much more inclined to start that patient on a medication. A patient comes in with a seizure, has a very clear lesion in the brain, has tuberous sclerosis, has focal cortical dysplasia that is very much consistent with the clinical symptoms of that seizure. In that case, you're more inclined to say that this patient has epilepsy, and you could consider, again, treating them for epilepsy. Or if there is a diagnosis of an epilepsy syndrome, again, you heard about Dravet syndrome just now, and I'll continue that example. Dravet syndrome is an inherited, not an inherited, it's a mostly de novo mutations in sodium channels or GABA receptors, which manifest with myoclonic seizures in infancy and childhood, where the first seizure is actually a febrile seizure often. And the Dravet syndrome, if you have the first seizure after a febrile seizure and you happen to know that they had their EEG is so abnormal and they had a myoclonic seizure, which was fairly prolonged, you can make a diagnosis right then that this patient has epilepsy. You don't have to do a whole lot more when that happens. So this is going to be the new definition for epilepsy going forward. We used to, when you and I went to medical school, we used to call them cryptogenic, idiopathic, symptomatic epilepsies. The proposed new term for epilepsies is pretty simple. Either we know what is the genetic cause, and Dravet syndrome is a good example where we know what it is because we can sequence the sodium channel, and that's what caused it. Where with the tuberous sclerosis would be another example where we know the cause is very clear. Others is structural metabolic, where we can see a focal cortical dysplasia, we can see mesial temporal sclerosis. That is, there are specific MRI findings that are known to be associated with very high risk for seizures or epilepsy. And if those 2 aren't there, you just say, I don't know it. And it's made very, very simple in the new classification. Most of the time, we had all these fancy names like idiopathic and cryptogenic. All we were saying, using long words, was, I have no idea why you have epilepsy. And I like to tell my patients, you know what? I don't know. honestly don't know why you had a seizure. And as an adult epileptologist, it's often my fate to say that. But that is accepting the limitations of what we know and what we don't know. So examples of structural metabolics, distinct metabolic condition is present, where there is clear, when I say febrile, I mean complex febrile, that is prolonged febrile seizures, followed by an MRI finding that shows lesions that are consistent with something that would generate seizures, that is malformations, old stroke, trauma, mesial temporal sclerosis. Those kinds of cortical lesions would suggest that there is a structural basis for epilepsy. So genetic, the basic concept is that the epilepsy is the direct result of a known or inferred genetic defect. Seizures are the core symptom of the disorder here. Evidence, what the league is asking for is getting a specific molecular diagnosis. I don't recommend anybody who's not a geneticist to order these tests. These tests are very expensive, and people who know, either a pediatric neurologist who's diagnosed with Dravet syndrome, when they send off genetic testing, they will have a very high yield. When general neurologists, leave aside primary care physicians, try to send off genetic testing, the yield is pretty low. So we know the people who can send off genetic testing. It's people who are experts at diagnosing genetic syndromes in epilepsy. When they suspect it and when they send off tests, and most institutions, they would restrict people from sending off genetic testing unless you have a clear sense. Though there is growing push to get more and more genetic testing, but unless there are specific reasons to do it, where you have a patient, and unless it's done by an expert, the yield tends to be low and the cost tends to be high. So specific abnormalities that are predictors for, and I use the word predictors for, they don't guarantee that you have epilepsy. If you see generalized spike wave discharge, or this is a discharge that occurs throughout the brain, or if you see focal spikes shown here on a EEG, then you would say that there is a high likelihood that further seizures would occur. That doesn't guarantee it. Has anyone seen a spike and patient not have seizures? All of us have. But these are the factors that we use to predict for a patient whether they're at risk for further seizures. So history, physical examination, findings on the MRI, findings on the EEG help you assess the risk, whether the patient is going to have more seizures, and begin to answer the question whether you should put them on a medication or not. So I usually have a discussion at this point when I have this data, especially if they've had one seizure and it's a college-going kid, in my case, or somebody young who's driving, and there are multiple other issues that they would consider whether they want to go on medication or not. And I'll go over pros and cons of taking a medication or not taking a medication, and what is the risk and benefit. And patient gets to choose whether that's the way they want to go. So there are practice guidelines on first unprovoked seizures, so which I intuitively said to you, but American Epilepsy Society and American Academy of Neurology put together a group of experts and asked them, what should you do when you have a first unprovoked seizure? So obviously you should do a history and exam, but EEG should be considered, and the evidence is level B, and MRI should be considered level B. All other lab tests, even though a lot of tests get done, really there's not much evidence that they change much. Of course, if you're in an emergency room and you suspect somebody has meningitis, you should get these tests. If your clinical suspicion leads you to do other tests, it should be done. But in a single unprovoked seizure sitting in an office, those two tests are the only ones known to change what you're going to do, and that's the Academy of Neurology and Epilepsy Society suggestion, and that's basically the summary of recommendation for first unprovoked seizure. So As I said, the classifications for seizures and epilepsy is changing. When you went to med school, or when I went to med school, we had simple partial and complex partial seizures. The idea was that the idea was that simple partial was a seizure which started in one part of the brain, but did not alter consciousness. The complex partial seizure in the old terminology was something that altered consciousness. If you were in the talk, at the lunch talk today, you would understand the difficulty of defining consciousness. It is one of the most difficult things to do is to figure out, I mean, half of you might be unconscious, but sitting here and asleep right now because, we lapse out and we start daydreaming. And when you're daydreaming, is that consciousness or unconsciousness? And anybody who's tried to examine patients while they're having seizures, and saw lots of videos, it's not that easy to tell whether the patient is just ignoring you or is the patient unconscious. And the epileptologist finally figured out that this consciousness business is pretty hard. So we've changed the term to dyscognitive features. We know that the cognition is somewhere off during these seizures or not. So the new term, when the kid's going to med school now, and the new Harrison's comes out, and you'll hear terms with focal seizure without dyscognitive seizures and focal seizures with dyscognitive features. And the idea is to move away from the concept of consciousness and move towards cognitive changes during a seizure which happen. So there was a video of a complex partial seizure. We can play it, or we have had plenty of videos, and I don't want to spend too much time. Can we play that? Just up. That didn't work. I tried. Okay. That's okay. That's okay. We can miss it. You'll recall from the last talk a complex partial seizure. Next slide. I'll go to the next slide. So during a complex partial seizure, what happens is this. There is a seizure focus. Imagine my seizure focus. It's been cut off here at the bottom of the brain, and right here. There's a seizure focus, and as the brain seizure activity spreads to both sides of the brain, your cognition is impaired. The patient's cognition is impaired. Remember, if the seizure is just in these parts of the brain, rest of the brain is still working, and rest of the brain can still do some of the activities that happen. And so your consciousness is not completely gone, but it is altered because the brain activity is going on. But what I want to point out is how I think about as somebody who does bench research and also takes care of patients about treatments for seizures and epilepsy. So if you were to take an electrode and stick it into the seizure focus and assume that the seizure focus is here, and you record from a brain cell that's generating it. So if you record from that neuron, what you'll see is a prolonged depolarization. And that is the membrane potential, as you know, it sits at -60. It'll go to -30, 40, and it'll stay there for a period of time. And on top of this depolarization will be repetitive action potentials, one after the other, okay? And it's a pretty monotonous thing if you've done it multiple times. That's what happens during a focal or a partial seizure. A prolonged depolarization of the brain cell with multiple action potentials. So if you're a scientist looking at it, you would say, I have two ways to stop this, right? One is that you can bring down this depolarization somehow, and this depolarization is driven by an excitatory postsynaptic potential. That is, it is a synaptic event. It's what we call a giant EPSP. This used to be debated 30 years ago. The scientists used to fight in bars whether it was or wasn't, but we know for sure that this is a giant EPSP, and these are repetitive action potentials. So The other way we can terminate these seizures is to stop these action potentials from occurring. And what you do in clinic is precisely that. So a series of drugs work on sodium channels. Remember that the action potential is mediated by inrush of sodium through sodium channels into a neuron, which causes depolarization and repetitive firing, okay? So what these drugs do is let me go back, is they sit outside in the extracellular space. When depolarization occurs, which is when a prolonged depolarization of a seizure occurs, they go into the sodium channel inside the cell, and then the sodium channel inactivates by a mechanism called where a particle off the channel just clogs off the channel by itself, okay? These drugs will bind to this particle and slow down recovery from inactivation. That is, you need more hyperpolarization and more prolonged hyperpolarization for this sodium channel to open again. That delays the firing of action potential and stops it. So it's almost, if you were designing a drug, this would be perfect because the drug doesn't even get in the cell, doesn't do anything till it's needed. When is it needed? When the action potentials go very frequently. So and it slows them down and stops them from occurring. So we've had this class of drugs for now almost 80 years. The first in class was phenytoin or Dilantin. I hope nobody prescribes it now, but it's still around. The class of drugs that work on this way are lamotrigine, oxcarbamazepine, and carbamazepine. Levetiracetam doesn't work this way, and lacosamide works this way. But these are the drugs that are commonly used to treat focal seizures. So let me start with, and they're in no particular order. Ideally, we would like, I think all of us would like to know what's the best drug to use. But there is no comparative efficacy study done for these drugs. As you all know, the way FDA approves drugs is you take 200 patients, you put them on a drug or a placebo. Usually they're on 3 drugs already, and you add a 4th one. And if 50% of them patients have 50% reduction in seizure frequency, you get a stamp of approval. Drug company makes billions of dollars. Physicians have no idea what to do with it. Because with that information, you don't know whether this drug, the latest drug that the drug rep is selling me, is any better than the 5 other drugs that I already have or have been using. Other than they will come up with some fake made-up ideas to convince you that the latest drug is the best ever made. And sometimes I just look at them and I say, seriously? Because 5 years ago you were telling me that then the one you were selling me was the best ever made. But we don't know. So I won't say this is the one. None of them pay me, so it's okay. Lamotrigine is commonly used. It's a therapy for partial seizures. It can be used for generalized epilepsy. It's gaining in popularity because of broad spectrum of anticonvulsant action. It acts on sodium channels to control repetitive action potentials, as I just explained. It also activates potassium hyperpolarization activated potassium channels, and that appears to most of the pure sodium channel drugs only work on focal epilepsies, but this one will work for generalized epilepsies too, and that appears to explain its dual actions. It's metabolized in liver. It has a half-life of 6 to 8 hours. Its metabolism is affected by valproic acid. The reason why some of the people, especially my residents, shy from using lamotrigine is because you have to start the drug slowly and go up slowly, because if you start fast or go up rapidly, there is a risk for developing allergic reaction or a rash. Again, the risk is small, but it is elevated in patients who are taking valproic acid. Generally, the drug is well tolerated. However, if you give too much of it, they'll have diplopia, dizziness. The way I give this lecture to my medical students, and the way you can remember the side effects of most of the sodium channel drugs is to remember cerebellar signs. Most of them have them. That is double vision, difficulty walking, ataxia, And these are all signs of toxicity. If you lower the medicine, they should go away. You shouldn't have to go to toxicity. As you just heard in the last talk, you'll know very quickly if a drug is working. If it isn't working, pushing too hard on toxicity is not a good idea, given that we have 10 new medications on the market. Chronic toxicity is limited. It has a mood stabilizing action. That is, it's approved for bipolar disorder. A lot of my patients, and I'll talk about depression in a bit. Depression is common, and especially those who come to see me, not because I'm so ugly, but because chronic epilepsy is associated with depression, and so they end up having it. It's been proved to be safe in pregnancy. So we can say that in large pregnancy registries, the number of teratogenic effects on patients taking Lamictal is not higher than. Does it have anything above 400? It will start slowing them down. Yes, cognitive problems begin. I mean, I've gone up to 600, but those are patients where nothing is working. But it does, at higher doses, I think there are effects, cognitive effects. So it's a broad spectrum antibiotic and used for both generalized and focal seizures. It's very popular for young women with generalized epilepsy because of lack of teratogenic. Carbamazepine and oxcarbamazepine are, again, excellent drugs. Most people no longer prescribe carbamazepine. Ox has become, they are very effective in simple partial, complex partial, and secondarily generalized seizures, or so-called focal seizures. They may worsen absence seizures, and they're used for trigeminal neuralgia. Only psychiatrists would remember that this was originally approved for treatment of depression, and epilepsy people stole it from psychiatry as a drug. These have pretty good tolerability, limited toxicity, and they're reasonably well tolerated. They're metabolized in liver and can be used. The next set drug and you heard about Keppra or levetiracetam. This is a drug with a unique mechanism, different mechanism of action than sodium channel drugs that I was talking about. This binds to synaptic vesicle protein. Remember, this is a cartoon of a synapse in the brain. The neurons are releasing neurotransmitters through these vesicles. So these vesicles are packed with a neurotransmitter, and SV2 protein binds to this levetiracetam binds to this synaptic vesicle type 2 protein and slows down the fusion of this vesicle with the presynaptic terminal. And it takes time and repetitive firing of neurons to actually see in the lab the effects of levetiracetam, but it's become pretty clear over the last several years that that's how it reduces excitatory transmission. And I talked about, when I showed you the cartoon for partial seizures, I showed you the depolarization. So it reduces the depolarization of neurons that drives the action potentials. So levetiracetam is extremely popular. I think I don't see a patient who hasn't been on levetiracetam in my clinic, because if they can be handled with levetiracetam, they don't send them to me. It's very popular for the reasons that pharmacokinetics are linear. You can rapidly dose the patient up. They tolerate it well. It doesn't have drug interactions. It has low plasma protein binding. It gets through the kidney. So all that is fine. The reason why patients come to me is the typical story goes, the wife brings on the husband. Well, the first time it happened to me was girlfriend brought him, and she said, "You can keep him. He's seizure-free, but I can't live with him anymore, and I'm leaving him right now." And he was crying, "Don't leave me." They become very irritable. Another story I tell my students is there's this wonderful young woman who was a TV reporter, actually, who was made the head for her condo association. And she had been the sweet angelic person, and I put her on Keppra, and then her mother brought her in, and she says, she's been writing nasty notes to all her neighbors saying, who left the garbage out, who didn't do this, who didn't do that, and they were ready to get upset. So irritability, anger, nobody is, to my knowledge, has become violent, but irritability, anger, depression do occur with levetiracetam, even though it's extremely well tolerated. That shouldn't prevent you from using it, but if you use it and you hear about it, be aware that that's what happens. Again, I see the worst of aggressiveness and irritability in my, it's first-line agent for partial seizures. It's also used for generalized epilepsies. Again, lamotrigine and levetiracetam are also popular. If I can't figure out whether my patient's having generalized seizures or focal seizures, then I say, okay, I'll try one of those and see if it works, rather than admit you to the hospital and figure out what the seizure type is, because there's some chance that one of those two will work on you because it works on both kinds of seizures. So when the first drug fails, you've just heard this, try mono, replaced with another first-line agent. When two drugs have failed, reevaluate the diagnosis before you start combination therapy. And that's when two drugs fail, I think it's best to send a patient to a high-level epilepsy center, because it's at that time whether you need to admit the patient to a monitoring unit, diagnose those seizures, make sure that these are not psychogenic, non-epileptic seizures, and go on with that. So I think what we find sad in our practice, and that I find sad, is somebody who has a curable epilepsy gets tried on 8-9 different medications for 8-9 years. They come in and I say, all you needed was epilepsy surgery, or all you needed was a specific drug for generalized epilepsy that needed to be given, and you'd become seizure-free. And when the patient's seizure-free after 6 or 8 years of going through lots of seizures, it's years of life lost to epilepsy. So my recommendation is, when you've tried one or two, do send them to a more specialized center. So generalized seizures, you just heard and actually saw excellent examples of myoclonic and other types of seizures. These include absences, myoclonic, tonic, atonic, and tonic-clonic seizures. I have lost the videos, so I won't bother with that. Clinical feature of absence seizure is sudden onset, brief loss of awareness, interruption of activity with blank stare. Classic feature is of 3 Hz generalized spike in wave discharge that I showed you on, earlier. Why these things happen? So one of the mysteries of, at least those of us who worry about mind and consciousness, is how can you go suddenly from being awake to unconscious? What brain activity would be such? Imagine, and we do that every day, actually, all of us. Actually, we fall asleep every night, right? Or some of us during daytime, also during boring lectures. But what happens is your thalamus in the brain controls the cortex, and the thalamus is the gateway to your cortex. That is, it is all the sensory information from your body, whether it's somatosensory, visual, auditory, others, are going through the thalamus. And thalamus' job was designed to switch off all that sensory information when you go to sleep. The cortex needs time to itself to process all that you've learned during the day today. Will be tonight during your sleep time. Your cortex will decide what was relevant, what was useful, what was garbage. Things like where you left your keys is garbage, right? You don't care where you left your keys yesterday, because today you may not leave your keys at the same spot. So what your brain does, your cortex does, is to sift through the information that was thrown at you throughout the day during sleep, saves the one that's relevant, that was emotionally significant, and throws the rest away. But how does that do it? It has to be disconnected from all the sensory information that's bombarding you all day long. So in sleep, thalamus says, okay, cortex, I'm not sending you any more data. You can sleep. you can do whatever you do during sleep. And we are still very mystified about what all goes on during sleep, but that's our current understanding of sleep. But the understanding of, and this switching off of the cortex or relay is done by setting up a rhythmic oscillation that is run from the thalamus onto the cortex. And a critical part of this oscillatory circuit is inhibition using a neurotransmitter called GABA, which causes hyperpolarization of these principal neurons of the thalamus. This hyperpolarization allows de-inactivation. Remember, I talked about inactivation of sodium channels. Calcium channels also get inactivated. It's the de-inactivation that occurs due to this GABAergic inhibition. And then when these T-type calcium channels get activated, allow you to sleep, and this set up this rhythmic activity that goes from the thalamus to the cortex right here. And we know this was shown in 1942, Dempsey and Morissette papers showing how thalamus was driving the cortex in sleep. And we know that this, now we know the molecular basis of this. So if you block these T-type calcium channels, what you do is you block seizures, okay? So, which is what your drug ethosuximide does. Ethosuximide is the drug of choice for absence seizure. Childhood absence epilepsy, the drug of choice is ethosuximide. It's an old drug, but then there's the only one comparative efficacy trial in our field in epilepsy where they compared ethosuximide, valproic acid, and lamotrigine, and all of us, the new guys thought, oh, lamotrigine would be so much better than ethosuximide, which is old drug, but ethosuximide was more efficacious and was superior to valproic acid because it has fewer side effects. So ethosuximide is the drug of choice for absence seizures, and it works on these T-type calcium channels to do its action. And we also know that T-type mutations in T-type calcium channels do lead to epilepsy. These are rare mutations, mostly reported out of China and Korea, but they're there, and which further supports the idea. In fact, Tracy Glauser, who ran the childhood absence study, has reported that polymorphisms in T-type calcium channels correlate very well with patients who don't respond well to ethosuximide. So there is some genetic basis to this also. So you saw beautiful examples of myoclonic seizures. These are repetitive brief movements of a group of muscles. EEG shows polyspike wave activity. And treatment now is, we try to begin with lamotrigine, but if it doesn't work, we have to think of others. Tonic seizures, again, is sudden increase in tone. Atonic seizures are different. Again, these are pretty tough to treat seizures. If you see a patient, often these patients have mental retardation. Often they are in pediatric age group. These seizures, it's best to refer them to a pediatric neurologist or an epileptologist to handle. So I talked about lamotrigine, topiramate. You heard about, if you were in resident talk, I thought the resident talk about weight loss, I don't know how many of you were there. I thought it was wonderful talk about giving these medicines, but we know of topiramate not as a weight loss medication, though it is but it is also a medication for treating generalized seizures. Lamotrigine, topiramate, zonisamide, levetiracetam, and then valproic acid, if all else fails, are drugs. So let me talk about comorbidities in epilepsy, and some of this is repetition, and repetition is good for learning and memory. You just heard about SUDEP in your last lecture, so I just want to remind you that I am pretty bad, and I must confess, I'm pretty bad about telling my patients that they can die from epilepsy. It somehow seems like a pretty negative message to give. But the truth is that SUDEP can occur. There are other comorbidities, accidents, injuries, depression and suicidality, learning and memory problems, bone health, and osteoporosis and fractures. All these are issues related to epilepsy and management of epilepsy. So let's start with SUDEP. You just heard that sudden unexpected death is someone who is otherwise healthy. No cause is found. The incidence is 1 in 1,000 for epilepsy patients per year, and 1 in 150. Since I take care of patients with refractory epilepsy, I can assure you, I do get that call, which your heart sinks. Sheriff's department calls me and says, "I have your patient," and I know the script after that. They were found dead, or in one case, they were witnessed to die by her sister. We don't know for sure, and NIH and the parents of these kids with SUDEP have been very active, and they've really pushed both the federal government and funding agencies to study it. There'll be a pretty large study starting next year on trying to understand the causes of SUDEP, and whether there are two leading hypotheses, as you can imagine. It's either the heart or the lung. Some people believe that during seizures, because of vagal nerve innervation of the heart or other factors, cardiac arrhythmias occur, slowing down occurs. In epilepsy monitoring units, all of us have recorded people who have prolonged asystoles during seizures. And in fact, I have patients who've been put on pacemakers after that. But others believe that it is respiratory arrest that causes death. And there is some evidence that during seizures, respiratory centers are depressed, and that could be. Some others simply believe it's choking. There's nothing much more magical about it, neurologic about it. Other things that we must warn is motor vehicle accidents. All states have laws. Typically, they don't allow driving for 6 months after a seizure. Burn injuries occur. I've seen plenty in my practice. Falls, drowning. And drowning can occur in a bathtub. That's one of the tragic things. I know a patient who drowned in 2 inches of water. They had family coming over. His wife just sent him out to clean the pool. And then she came out to find him dead in the pool. He had just gone out to. So drowning doesn't require swimming in a deep ocean or something. Even small amount of water can be dangerous for patients. So the next thing I wanted to talk about, I think these slides got mixed up, is learning and memory. Let me just talk about depression a bit and then get to learning and memory. Depression is pretty common in patients with epilepsy, especially patients with focal epilepsies. Always ask, what's your mood like? Especially in adults, where, again, people with refractory epilepsy tend to have worse depression. But depression doesn't have to be just because you're having a lot of seizures. In fact, if you risk adjust asthma versus epilepsy, patients with equally severe asthma would have far less depression than patients with epilepsy. So we think seizures themselves, an underlying cause of seizures, epilepsy itself, causes depression. The brain circuits that are involved in depression appear to be also affected by epilepsy. So in fact, there are studies showing that some patients have depression 5 to 6 months before their first seizure of an epilepsy. There's a very good study showing that. So depression is biological in our patients with epilepsy, and it's important to ask about that. So I just mentioned that brain structures involved in pathogenesis of epilepsy may be involved in this. So next is the most common complaint. If you take 1,000 patients with epilepsy, what's the most common complaint that they would give you? They would say, I have memory problems. After complaining about seizures, of course, they'll say, I have problems with my memory. I don't remember things as well. I'd see people, I can't remember their name. I do that too, but I don't have epilepsy. But but they really do. And the best studied are patients with temporal lobe epilepsy, and I'll just explain why. These memory deficits, we can measure them with neuropsychological testing. We can correlate them with MRI pathology. And in patients who have already suffered a memory loss, going through surgery does not cause further memory loss. So Often when we are counseling patients about surgery, they say, will I have any memory left after you're done with me? What kind of adverse effects would I have? And that often is the reason why many patients hesitate to undergo surgery. But you have to explain that if you've already suffered a memory loss, that's not what is going to make it worse. And that's because when we store memory, we store it in this mesial temporal structure called hippocampus. So when I'm trying to talk to you right now, what I'm trying to do is to modify this structure in your brain so that you can learn and remember. And then when you go to sleep, you'll decide how much of the stuff here gets stored. Next morning, your hippocampus is fresh for learning and memory. How does hippocampus help us remember has been studied in rats for like 30 years, 40 years. And what you do is you take a rat and you make them run on an 8-arm maze, and you put these electrodes in their brain, in the hippocampus, try to record from cells. And this is one of the coolest experiments to do. I've done it, and I can tell you, so when the rat gets into one specific spot, so this is the spot, this cell will start firing like crack, 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 crack. So it says, I'm here, tells the rat, you're here. So that had been the theory. It's called the theory of hippocampal place cells, or cognitive map. That is, you carry, when you wake up middle of the night in your house and you have to go to your restroom, you don't switch on the light because you know exactly where it is. You step, you go, you get to the bathroom, then close the door and switch on the light so others are not disturbed. That is because you have a cognitive map of your house place. But when you go to a new hotel and you go to sleep, you have to switch on the light, find the bathroom, because you don't have a cognitive map. But they did a pretty cool study. I love this study of. So in London, they did this study where they told a cabbie that you had to remember the route going from this spot, Grosvenor Square, to Elephant and Castle. And the cabbie had to be in an MRI, and they had to either remember a film plot, famous landmark, or route. And the idea was that if the hippocampus stores this spatial memory, and the cab driver in London would instantly know how to go from one part of London to the other because they have to have a cognitive map, then the hippocampus should light up in that. Oh. That slide is missing. So you'll have to believe me that what happened was the right hippocampus does light up, just imagining the route that they had to take in London, suggesting that even humans carry a cognitive map of the world around them in the hippocampus. There are other arguments about this, but I wanted to show you that there are structures in the brain that we can now begin to localize where learning and memory are being stored, at least transiently. And these are the very structures that are affected by epilepsy. That's why it's important to ask our patients, do you have problems with learning and memory? And that's equally important in kids who are going to school. If they can't learn in school, they'll fall behind. So let me turn to the last part of the talk, which is to manage women in childbearing age and beyond with epilepsy. So first thing, most important thing is to advise women with epilepsy that they can be teratogenic effects of anti-epileptic drugs, and they should be counseled about it. The drug that everybody should counsel against is valproic acid, is known to impact cognition of babies born to mothers taking epilepsy. Valproic acid has the highest effect on major malformations. Second, you heard about topiramate. Babies born to mothers taking topiramate through the pregnancy have on average, 100 grams lower birth weight than controls. Now, if a woman smokes through her pregnancy, on average, the birth weight is reduced by 50 grams. So topiramate is smoking twice as much. So that's the effect. When I teach my residents, I say, why would you give a young woman for migraines topiramate because it's pretty popular, but that's the issue. Polytherapy poses a risk. Folic acid is known to reduce the incidence of neural tube defects. All women in childbearing age group who are taking anticonvulsants should be on folic acid. That's a recommendation. We don't know how much. And screening in early pregnancy can detect neural tube defects. Seizures pose a risk to pregnancy, so we recommend that patients be seizure-free before they become pregnant. Risk of premature bleeding and contraction are not increased by anticonvulsants, so that should not be. Again, some of the new anticonvulsants, lamotrigine and levetiracetam, their blood levels decline during second trimester. So anybody taking a woman through pregnancy should know that their levels will decline. So I make sure that I have their blood levels when they're well controlled before they get pregnant, and then follow them along. The highest risk for seizures in women with epilepsy is soon after birth. We don't know whether that is because they're staying up with the baby and staying up all night taking care of them, or is it because of the hormonal effects? Women experience periodic exacerbation of seizures with epilepsy. That is, there is worsening of seizures in mid-cycle and end of cycle. So I see quite a few women in my clinic who say, nobody believed me when I said that, but that is well known and accepted part. Currently, the progesterone trial failed to show efficacy, though there may be further attempts to use progesterone. We don't know exactly what's the best treatment. Sometimes I use benzodiazepines. Sometimes I tell them to take a higher dose of the anticonvulsant towards the end of cycle. So some of the older medications were enzyme inducers. They could cause a worsening of bone health, and so they have to be screened. Postmenopausal women should always be screened for osteoporosis when they're on anticonvulsants. Let me just stop. Seizures and epilepsy are common. Methods for evaluation are standardized. Many treatments exist. Multiple comorbidities exist. If you see a woman with epilepsy, please make sure that there are other aspects that are taken care of. And I'll stop there. Thank you.
For people who develop seizures after some sort of trauma to the brain, so like a traumatic subdural, do they need to stay on their anti-epileptic for the rest of their life, or does that effect wash out after a certain amount of time?
How many seizures?
So like my dad had, I think 3 or 4.
3 or 4, and nobody should ever, my teaching is, even though lots of adults with epilepsy tend to have prolonged course, people who have been seizure-free for 2 years, 3 years, 4 years, 5 years, should, at every anniversary, I ask them the question, would you consider coming off of medications? We should at least have a risk-benefit analysis. And the risk for recurrence of seizures is higher in patients who've had neurological deficits, cognitive effects, difficult to control seizures, requiring multiple medications, or those who've had a defined epilepsy syndrome known not to remit. Having said that, it's my general feeling that even though the incidence of seizures and epilepsy rises in older age, with growing age, the seizures tend to grow milder and milder. And I think there is tremendous over-treatment of elderly with epilepsy anticonvulsants, because elderly will take 20 pills a day, because if you tell them, they'll do it, unlike 18-year-olds who will stop taking it the 2 weeks after, the exam week is not a week to take medications. So it needs to be considered very seriously. I can't say one size fits all, but that's a discussion I have recurrently. I mean, I can tell you, I had a patient who's 89. She was put on phenytoin when it first came out in 1936, and I finally convinced her to get off phenytoin, and she said, "You'll kill me," and I said, no, we should try it, and she's seizure-free now.
How many years seizure-free before you take them off?
So The best studies come from England. What they do is these large, massive scale studies where national practitioner database, and what they found is longer you wait on seizure freedom, greater is your chance of coming off successfully. So 2 is the minimum. Nobody recommends coming off before 2 years, but if you wait 3, that's better than waiting 4. That's better than, so each year, longer you wait, but at 4 or 5, I think it's important to have a discussion of what's the risk of seizures. Having said that, I've had at least 2 patients where I took them off after 10 years of seizure freedom, and they had seizures again. Both of them had mental retardation. Both of them had high risk of recurrence. I said that you have a high risk of recurrence, but I did feel that they shouldn't spend the rest of their life on anticonvulsants. But it happens. That can happen. Again, mental retardation is usually considered a contraindication for withdrawing medication. So I said, most physicians would advise you to stay on it forever, but I want to see. And they had 6-8 months of seizure freedom, and they came back to haunt me. They are what? It would be expensive. You know, that one night of admission in the EMU would make me rich, but it would be expensive imposition on the healthcare system. And it is a challenge, and adolescents pose a specific challenge because, you know, that's the age when you believe you're indestructible and nothing. What is a seizure here and there? And I practice in a college town, so exam week is terrible for withdrawal seizures because they stay up all night and then they party and then they have a seizure just before they're packing or parents are packing them to take them home. So I wish I had a magic formula for scaring them. Oh yeah, nowadays, yes. iPhones are ubiquitous. Everything is being videotaped. Usually that's their family or friends will videotape and bring them. Okay. Yes, sir.
In patients who are taking a high dose of anti-epileptic, but their levels are still low and they're still having seizures. I have a patient who has complex partial seizures and is on Lamictal 600 milligram a day, with a level in the subtherapeutic, in low therapeutic range. Would you keep pushing the dose?
At some point, it becomes, the truth of the matter is that at some point it's futile because how many times can you see that patient in your clinic and push it? And given that you have other drugs such as levetiracetam, which you won't have that problem with, or zonisamide or others, at some point when Navin and I were fellows together, when we were fellows, there were only 3 drugs. Then we would push everything and push our hard. But now that we have 9 or 10 drugs, and I tend not to fight it. If it's not working out, move on to the next drug, because we can usually find something else. Thank you.
Thank you.